for a glioblastoma, a brain tumor that you've been diagnosed with and had surgery for. Looking at this, it looks like you kind of came in with a couple things going on at the same time. You had this Guillain-Barré, and you also had some left facial droop, and as the treatment for the Guillain-Barré went on, the left facial droop didn't seem to get better. And so they went looking for why that might be, and they found a mass in the brain on the right side.
Yeah.
They did surgery and took out as much of it as they could safely take out, and they showed on pathology that this was a glioblastoma. And they were going to send that away for a couple extra tests. I haven't seen the results of those yet. I didn't know if anybody had mentioned MGMT status to you.
No.
Okay. So sometimes it takes them a few weeks to cough that up. So I'll just keep poking them until I get it.
Okay.
It doesn't really change how we treat you. It just changes basically how well you're going to respond to the treatment we give you. There's this specific thing inside some glioblastoma tumors that if you've got it, makes them respond better to treatment. That's all. But we tend to do the treatment similarly for patients with this MGMT promoter methylation is what we're looking for, or not.
From what I understand, I thought there's one larger one over here that they got out. Most of it, or a big percentage.
Yeah, it's quite smaller. Yes.
Okay.
So it looks like they did a nice job with surgery. Usually we don't stop there because these types of tumors, being in the brain, we can't do surgery like we do for tumors elsewhere in the body. So if you find a cancer somewhere else, you like to take out the cancer and a rim of normal tissue around it. But we can't do that in the brain because that rim of normal tissue is doing important things. So that is combined with the tendency of these glioblastomas, these brain tumors, to have fingers that reach deep into the brain. And we can't see them with the MRI, but the pathologist can see them. So even if we take out a bunch of area that looks normal, which would have significant consequences to the functioning of your brain, we would probably not get to an edge that doesn't have much tumor in it. So the tumor reaches beyond the part that we can easily see on the MRI. So for those two reasons, we actually add radiation after surgery for patients with glioblastoma that are recovering well after the surgery. So the radiation that we add treats the area of the tumor we can see and a margin around that to try and catch some of the extra cells that are hiding from us but we know are there based on the characteristics of this tumor. And the dose of radiation was picked a few decades ago when they tried out a couple different doses in clinical trials and landed on this 60 gray, which is kind of the standard dose, which ends up being a 6-week course of radiation. And they found that in patients with glioblastoma, if you add chemotherapy, and then the results are better. And that was actually published, I think it was 2005. They came up with this combination of radiation and temozolomide, which is the chemotherapy pill that you would take during the radiation. And you take it during the radiation daily, and then after the radiation they switch up how they give it to you and give it to you in higher dose 5 days out of the month. And they do that for a good 6 months or so after you finish, as long as you're tolerating it and the tumor is not getting bigger. And sometimes they consider whether or not to continue it past that 6 months, but usually it's at least the combination with the radiation plus approximately 6 months of temozolomide. So some of the more recent things include kind of looking at shortening the radiation regimen for patients with age greater than 70 or giving either radiation alone or chemotherapy alone for patients who have what we would call poor performance status, so folks who aren't doing so well after surgery. So Claire was telling me that you're recovering pretty well. I see you're in a wheelchair, but she says you're not in a wheelchair all the time.
No.
You're up with a walker at home?
Mm-hmm. And he
Yeah.
walks by himself quite a
Okay.
bit.
Or with a cane.
You don't use the cane because that scares me.
Oh.
But you do walk by yourself. He
Yeah.
goes from one thing. He
Okay.
walks quite a bit.
And how long is the walker just after the surgery, or was that before the surgery? When did you start needing the walker?
I think it was after, wasn't it?
No.
I think you were using a little bit before because your left. That's why we went.
Right.
Is because your left side was not working.
I
Both
guess
parts
so.
was not working. So we had to put you in something. So we used the walker.
Okay. And is that getting better or worse after the surgery?
On my left side.
You're walking better.
Yeah, I
Much
think
better.
I'm walking.
Good.
Well,
It's hard to remember all this.
Sorry, your question?
no, I was just gonna say, if you're not aware, he's doing occupational therapy twice, and physical therapy was just yesterday, and he walked for,
4 minutes around
yeah,
the.
so
Very
I just wanted
good.
to let you know
Yeah, I
that.
walked a lot yesterday.
Yes, you did. It scared me.
So, how do you do with things like getting dressed? Are you able to get dressed on your own?
Mm-hmm.
How about if you wanted to fix yourself something to eat? Can you do that on your own? Okay.
Oh,
And-
mine food's not very good. Yours is best.
I'm not looking for equivalency in quality. I'm just trying to understand kind of how much you can do.
I can do.
Okay. If you are showering, are you able to do that on your own?
Mhm.
Okay, good. So I hear you're not really having much in the way of pain, and that any pain you have seems to be managed by Tylenol.
Mm-hmm.
Good. You've just come down off of prednisone, and you were feeling a little bit more energetic on the prednisone, it sounded like, and you're feeling a little bit less energetic now that you're off of the prednisone. Now you tapered off of that. What was the last level you were on?
It was one pill, and it was on Monday.
But do you know, was it 500 milligrams? You know what I don't know what the
Little
dose.
teeny tiny pill.
They're all tiny, I'm afraid.
Some of they were half, and then they're whole, and the last one was a whole one.
But they were giving me a whole one, then they broke it down to half, right?
Yeah. So they tapered, and we just went down like that, and slowly. And
Okay.
but the last one I gave him was a whole one, and it was Monday.
Okay. So
I think she goes by how I feel, but I think you need a whole one today.
Oh, no, I
No, we
didn't do
know.
that.
It was all the doctor who set it
I
up.
didn't do
Yeah.
that.
You
okay.
didn't?
So the thing with steroids is they can do some very nice things in the short term, and they can cause problems in the long term.
Oh.
So I'd encourage you to kind of give it a few days, and if the tiredness gets worse and worse, then maybe we'll need to return to those steroids for a little while. But if it levels out and then starts to get better, because usually